Hello everybody, this is Aaron Lau once again with the school project wrap-up. Today we are covering a case study of a 13-year-old female patient I had recently who came to the clinic with chronic lateral patella dislocation and patellofemoral pain syndrome. What we wanted to find is the best way of treating this patient in relation to the previous thoughts on patellofemoral pain and its causes. So today we're going to discuss the case description, the patient, and the specifics of her injury, the knee kinesiology principles and how it applies to her, the current thoughts of how we should direct the rehabilitation, the actual application of the rehabilitation for this patient, and her personal outcomes. So the patient is a 13-year-old female who came to the clinic with, I believe it was 3 times she'd had a lateral patellar dislocation and associated pain with that and with just daily activities. Unfortunately for her, her x-ray shows that she has a flattened trochlear groove. She did present with a slight exaggerated Q angle as compared to industry standards and genu-valgum at the knees. She was slightly overweight but was active with sports and school activities and did not appear to live too sedentary of a lifestyle. Her pain was typical when she was doing activities such as running, stairs, and playing with her friends. So some basic kinesiological principles. The knee is a basic hinge joint comprised of the femur, the tibia, and the fibula. There is a slight little bit of rotation right at full extension, considered to be the screw home mechanism. With that is the patella. It's a free-floating sesamoid bone that increases the lever arm of the quadriceps to give us greater strength and force with knee extension. The patella sits superior to the knee when our leg is extended, and as we flex the knee, it drops down into the trochlear groove. The patella is situated within the quadriceps femoris tendon, and it is also held in place by other soft tissue such as the retinaculum that is surrounding it. And when the biomechanics of the knee are off, the kneecap is not tracking properly within that trochlear groove, and you can get a lot of pain, or such as with our patient, you can have it as bad as a dislocation. So we wanted to find out which direction should we go with her rehabilitation protocol. Previous thoughts have stated that the Q angle of the knee can have a significant part in the patellofemoral pain as well as the biomechanics of the knee. Also that a patient's weight could contribute to the pain, and what other strategies we would be able to incorporate to help bring the best outcome for her. And with the strategies that are out there, try to find some relevant research that could show validation for using it. So the Q angle is the measurement between the midline of the quadricep muscle in relation to the patella and the patella tendon. It is typically a greater angle in females compared to males, and was previously thought to cause an irregular biomechanics of the knee with flexion and therefore causing pain or contribute to dislocation. A study in 2016 by Almeida and associates in a cross-sectional study of 22 females did not show validation that the Q angle was a contributor to patellar femoral pain or possible dislocation. We also looked at the patient's weight. Weight can obviously have a great contributing factor to knee pain, as the knees are required to carry the entire body, and all the energy and force of jumping, running, activities such as that can translate the energy right into the knee and the soft tissue in that area. A study by Barbara Foss and associates in 2012 followed an entire school district for a season, about 248 young female basketball players, and they were unable to validate the claims that a patient's weight could be a contributing factor to patellofemoral pain. So we asked what strategies had been proven. A previous case study done in 2011 with a 15-year-old female athlete showed that a plan of care that was directed at specifically hip musculature strengthening and proprioceptive retraining showed great results for the patient. She was brought in and given just a few exercises, and after demonstration that she understood them, was sent home with an HEP. She returned the next week stating that she had elevated pain, but it turned out that it was actually her poor performance of a step down exercise, so they changed that, incorporated some different ones, and she had no more issues after that. In subsequent sessions, they just progressed it continually into more balance activities with perturbations, and at a 6-month follow-up she was pain-free with no issues. The next study that showed proven strategies actually was a comparison trial. They tried a knee-specific protocol to a hip protocol. With the knee protocol, they tried to specifically target just the quadricep muscle, although they did acknowledge that with the exercising that they were doing, that some hip musculature was obviously going to be included. Kind of hard not to and rule them out separately. But the hip protocol cut out any hip flexion to not have the influence of the quadriceps, and instead focused on hip abduction, adduction, extension, internal and external rotation. Both groups showed an improvement, with about 2/3 of all participants showing an improvement, but the hip protocol had the fastest recovery. So with all that in mind, we figured we had the information we needed to be able to apply the best plan of care for this patient. We followed along with the previous studies formats. Most of them focused on a open chain motions in the first phase, with a progressive resistive exercises continuing on into the next one, where they stepped into the closed chain, again focusing on progressive resistance as the patient could tolerate, and finishing out with either high-level functional activities or return to sport specifics. This patient was not in any organized sports. It was mainly just playing around with friends and at school, so we just focused on high-level functional activities. Throughout this, her neuromuscular re-education was performed with different phases of balancing, with adding perturbation and changing out of basis support and center of gravity. Throughout her therapy, we were applying modalities such as electrical stimulation with cold pack to relieve symptoms. That didn't last too long because typically her pain was only with activities. We were doing manual therapy to help loosen up any tight restricted tissue around the knee that could be affecting and contributing to her lateral dislocation. And throughout therapy, we were applying kinesiology taping with the focus on assistance to helping the patella tracking. The patient demonstrated great outcomes after 6 weeks. From the start of therapy, she did not report any more lateral dislocations. She was having some pain when she was doing stairs and if she was doing any kind of activities where she was planting and turning, but the pain had decreased. significantly. Patient was reminded on proper body mechanics, given a home exercise program, and was discharged from therapy. So in conclusion, we found that patellar instability can be a common cause of patellofemoral pain, especially in the young female athlete population. The current research has mostly debunked the previous thoughts on what could be a significant factor in influencing the patellofemoral pain, and we've shown that the clinician would be better suited at addressing hip musculature and the treatment of the biomechanics and muscular imbalances to help treat the patellofemoral pain. And with proper therapy application, patellar issues and pain as well as dislocations can be easily treated in the physical therapy setting. Thank you for your time.